Good morning, everyone. Good afternoon. Thank you for joining. We'll get started with this webinar shortly. Hi there. Thank you for joining. I can see you're all connecting. We'll get started in just a moment with this session. All right, fantastic. So greetings, everyone. A very warm welcome on behalf of the Alliance for Malaria Prevention to this webinar titled Geo-Enabled Microplanning for Insecticide-Treated Net Campaigns. Just a couple of important housekeeping notes before we do start today. This webinar will be interpreted into English, Spanish, French, and Portuguese. You will see on the Zoom menu bar the interpretation button. If you haven't already, please select the appropriate interpretation booth now. There will be a presentation in French, so please make sure to select the correct booth. And for the benefit of our international speakers who have already joined us,
Y para escuchar la versión española se puede hacer clic en Interpretación en las opciones de la reunión de Zoom y seleccionar el canal español. Pour écouter la version française, il faut cliquer sur Interprétation dans les options de la réunion de Zoom et sélectionner le canal français.
Para escutar a versão em português, por favor, clique no botão Interpretação nas opções da reunião do Zoom e selecione o canal de português.
and thank you very much to our interpreters for your support with this session today. There will be time for discussion during the webinar today, and that will be after our presentations. If you take a look at the Zoom options now, you will see a few buttons, and these include a separate chat and Q&A area. Please use the Q&A option to ask questions for our speakers. The moderator will not be monitoring the chat during the discussion time, so your question may be missed. So just to repeat that, we use the Q&A option for any questions to our speakers, and then the chat may be used for general comments. And just a reminder that myself and my colleagues are in the room to support you if you have any technical difficulties. Our email is on the screen, or you can reach out to us in the chat for support. There will also be some Mentimeter polls included in today's webinar, and also look out for the feedback form, which will be shared in the chat at the end. For now, we will start with a quick Mentimeter poll to get us going. So on the screen now, you can see login details, or there will be a link pasted in the chat as well. So you can scan the QR code on the screen with your mobile device, or open a web browser and type in menti.com and enter the code 89527632. That's the code 89527632. So if you could do that now and connect in, you can let us know where in the world you are dialing from. That's our first question today. I can see it all dancing around the screen, which is fantastic. Great that we have some answers coming in. So as I watch you join, I'm now going to hand over to Giovanni De Sarbe. Giovanni, over to you. Thank you very much. Giovanni, you there?
Thank you, Hazel. Good morning, everyone. Good afternoon, good evening, depending on the time zone you are in. I can see we are coming from the four corners of the world. So my name is Giovanni De Sarbe, as Hazel mentioned. I work for AMP, Alliance for Malaria Prevention, and I'm going to be facilitating today's webinar. It's my pleasure to welcome you. Thanks for joining us in big numbers on this geo-enabled microplanning for ATN campaigns. The big number of the registration just a reflection of the interest in this topic. It is also a recognition of how important this topic, the microplanning, is for the successful and effective ATN distribution campaign. Some of the tools we currently using or we have been using for microplanning include maps, usually hand-drawn maps, and we use those maps as the basis to plan the movement of the teams in charge of household registration, the supervision and monitoring teams, as also take some decisions related to the distribution of distribution points being fixed, outreach, mobile. However, as we have been realizing, or as we know, those hand-drawn maps present some challenges. Some of them include that they cannot be updated easily without having to redraw them. They are also difficult to share and to archive so that we can use them in the future. They don't provide accurate population distribution information within the catchment area. They cannot properly feature accurate and precise position, region, scale, and also they are prone to human error. So the use of geospatial data and tools can help address some of those challenges. There are some past ongoing initiatives by some national malaria programs and also other health interventions to improve the microplanning process using geospatial data and tools. Our speakers today will help us understand the benefits of using those tools and also sharing lessons learned, opportunities, challenges from different initiatives that have been undertaken across different settings and health interventions. It's clear that there's much to learn. We need to reflect as how we learn from them and how we integrate them into our practice. For this webinar, we are fortunate to be joined by different speakers and presenters, including national malaria programs from Burundi, Zambia, Nigeria, from World Health Organization, Grid 3, across MAP Action. We'll hear from each presenter for about 15 minutes each. Following that, there will be an opportunity to ask questions. As Hazeda mentioned, the questions will be based on the questions you pose through using the question and answer function. Menti 2, Russell, we're gonna ask you a simple question as a way of do you have any experience using geospatial tools for microplanning in your country or in your work? We are getting mixed responses, but you can see many of the participants today don't have experiences. So I guess there will be a good opportunity to learn from those who have been having experience. The second question, Russell, which interventions for those who have been using geospatial data and tools, which interventions did you implement microplanning using geospatial tools? It can be for mosquito nets, IRS, EPI, SMC, COVID, or other. Good. It seems there are some experiences across different health interventions. Now I'm going to hand over to the first speaker of today from Chris Junk from WHO JS Center. Thank you, Chris. Chris is part of the team that developed the Geo-Enabling Microplanning Handbook, and handbook that aims to provide guidance on how to integrate geospatial data and technologies into the microplanning process. So over to you, Chris.
Thank you, Giovanni. It's good to be with all of you today. I'm looking through where most of you are calling from, and I see a lot of you are in different parts of Africa. I myself have been living across Africa for about 11 years, but right now I'm talking to you from Sofia, Bulgaria. So it's good to be with all of you. Yeah, so I will give the introductory talk here and a little bit of the landscape of how this work is coming together globally, and start, I think, with sort of who I represent and where I'm working. Let's see. There we go. So we'll talk about a couple of topics here, the global coordination for geo-enabled microplanning, as well as the handbook that Giovanni mentioned, the handbook for geo-enabled microplanning as well. Okay, so I am with the World Health Organization, and in particular, WHO's GIS Center for Health. So the GIS Center is a service center. It's in service to the rest of the WHO organization at the 3 levels, the country, regional, and headquarters, but also to our partners. And the goals here are really to use maps, apps, data, and the people to support this geo-enablement work and geospatial work to target and deliver more effectively our health services. So the GIS Center was founded about 2 years back, and it's been growing and getting involved in more of these types of advocacy and technology projects. In particular, we've been working with a COVAX GIS working group for the last year and a half or so. This is a WHO UNICEF-led working group. And as part of that, we've been supporting some of these countries with GIS microplanning for COVID, but also for other needs such as ITN campaigns in some of the countries that you all work in. We also have a global community of practice that we've launched in the last couple of months. This follows a technical partners initiative that we had going for quite a while, and we've reformulated this to work with countries, both within our WHO and UNICEF country offices, but also our technical and implementing partners and our government partners across the world as a venue for knowledge exchange for how to best do this GIS microplanning, to be able to share experiences among ourselves, to work on coordination issues, to find those gaps that we need to fill, and importantly as well, to set some global standards, best practices, talk about strategy, good working principles, and also to start to work on some global goods and some tools that we can all benefit from. These are some of the partners that we've engaged with, both to learn from and to pass information to over the last year and a half or so. And we're happy to work with many more of you going forward. Okay, so a word about accessibility modeling, which is really kind of in the heart of what we're doing here, and microplanning in general. So microplanning is a set of decision-making steps and tools to ensure that health services reach every community. So it helps us to identify and prioritize and allocate resources to address barriers to access and to make sure that we do really reach everyone that we want to reach. There are a lot of different layers of data that are going to go into that. We'll speak about that in a moment. But at its core, it's a very local exercise. The macro plans are developed nationally, but when we really want to know where are these people and how do we reach them at the household level, how do we make sure that every child gets their vaccination or every household has the bed nets they need, in our case, we need to know where these people are in precise detail, where our facilities are, and we need to connect the two. And that challenge, we've worked on that in the past through more traditional means. It doesn't require sophisticated technology in order to draw a map. But hand-drawn maps have their limitations. Obviously, they're more difficult to share. They're less accurate. They require a lot of time to develop in person as you're doing these things. But essentially for us also, it introduces a level of sort of the information that gets captured in the maps is only the information available to the people who are in that room. When we can bring to bear more data sources and more data layers, such as satellite imagery, spatial population layers, we can look at our facilities, our catchment areas. We can do the analysis to create the travel time and the drive time between the people and those facilities. We have the ability to make this much more precise and much more inclusive. And the inclusive part is really key to what we're trying to achieve here. We want to make sure that marginalized communities are not missed, that vulnerable populations have access to care, that every last person is captured in this using the most recent satellite imagery and most recent population estimates that we have. We also, when we find gaps in that, we want to be able to update that information for our next rounds. You know, our ITN campaigns are a never-ending thing. You know, every 3, 4, or 5 years, we're doing these campaigns, and we're also doing the routine distributions in between those dates. So as we go through this process, it's very important to continue to update our data layers to make sure that we capture everyone that we can. So population estimation and the spatial distribution of that population is a key thing. This information starts with our satellite imagery and remote sensing data, but really does get improved by our ground truthing and the people who go door to door and understand where these populations are. What we're really trying to answer is how many people do we need to serve and where are they? And that will give us the questions of how many nets do we need at each distribution point, and how large of a staff do we need to cover that catchment area. It's not just about how many people we need to serve, but if those people are spread in a non-concentrated way, we're going to need more project staff and program people, perhaps more vehicles to reach everyone that we need to. So those questions are all tied into this population estimation and distribution. Forgive me if I'm going a little fast, but we have a lot to cover and I want to make sure we stay on time. So geographic accessibility modeling is another key element of this. And what we're really asking here is, where do we want to stage our locations for distributions of ITNs? We want to make sure that everyone's covered without having too much overlap. We want to make sure that our populations, especially our vulnerable and marginalized populations, are there. And what we're really targeting is equitable access, so that everyone has access to the services they need through the nets that we can provide. So one of the ways that we've been working on advocating for this and providing as much technical guidance as we can is, over the last 15 months or so, this has been a long process. We've been developing through partnerships a geo-enabled microplanning handbook. And I'm happy to say that we are in the final stages of editing this handbook. It is a crowdsourced document that is really a step-by-step walkthrough of how to design and implement a program at the country level, or at even a district level. We want these programs to be capacity development led, so that they're sustainable within the country, and that's really a focus of the handbook. And it's built on existing guidance documents. There are quite a few documents that have come before, and we tried to synergize and to make sure that aligns with guidance from our partner organizations and previous work that WHO has done in many contexts, including in polio. So We have been coordinating this through the WHO UNICEF COVAX GIS working group, which I mentioned before. The Gates Foundation has been quite helpful with supporting this work, as well as many others, including technical guidance from CDC and Gavi, Global Fund, World Bank. And we've worked with a couple of other organizations, including Dev Global Partners and Health Geolab Collaborative, for the coordination and the development of this document. Many people have input into it, around 113 co-authors and reviewers at this point. And we're so grateful to all of them for having brought us this close to the finish line here. And we do hope to publish this in the next several weeks. I think as soon as we can get these last edits together. Just a quick visual here. There are two tracks within the document. We say it's bifurcated for two audiences. One is for program designers, people who would be doing the budgeting or the human resource allocation or the advocacy work to say what the scope and scale and reach of these programs need to be, and what resources do we need available to us to achieve that. The other audience are more technical GIS staff, and we'll be working with those people in a more so a technical way, right? Looking at the GIS systems, looking at the data layers that would need to be input into the work, the software systems that would do the analysis, and both aspects of this are covered in the document. In parallel, we've also been developing an online e-learning course. It is the same content as the handbook, but we think that some people will find it more accessible to learn through this e-learning format. It's 9 modules, targeting about 6 hours of content. We're developing in English with plans to translate into French and probably Spanish as well, although we're still, the third language is yet to be confirmed. So if you have strong preferences for languages beyond English and French where you'd want this translated, please do let us know. As I mentioned, the document is bifurcated by those 2 audience tracks, and the e-learning is split that way as well. And it will be hosted on Agora, which I think originally is a UNICEF learning management system, and we'll be putting it live there within probably a couple of months. So I want to say thank you for everyone for having me today and letting me talk about our work. Here's the link for WHO's GIS Center, and we're happy to engage in terms of strategy or implementation support, guidance, coordination, or just to learn about what you're doing. We're always happy to hear about the great work that you're doing in country levels, so that we can learn at the headquarters level and pass that on to our regional and country offices as well. Thank you, Giovanni. I'll pass it back to you.
Thank you, Chris, for the good presentation. I think it's a good way of resetting the stage for the country-specific experiences. Now I'll hand over to the next speaker, Fred, who will be presenting on the Burundi experience. Fred is not, unfortunately, is not around. He has prepared a pre-recorded presentation, and I will ask Russell to play the presentation. Over, thank you.
Bonjour, je suis Fred Lamy, je suis consultant avec AMP, je suis en charge de l'aide pour la numérisation des campagnes de masse. Et dans ce cadre-là, nous avons soutenu un projet au Burundi, un projet pilote dans l'utilisation des outils de systèmes d'information géographique dans le cadre de la micro-planification de la campagne de masse Milda. Le plan de présentation, je vais dans un premier temps vous présenter un peu l'arrière-plan du projet. Les livrables, évidemment, nous n'allons pas aller dans tous les livrables parce qu'en fait, le temps que nous imparti nous oblige à aller de choisir les livrables les plus pertinents. Et nous allons aussi vous présenter, par exemple, un échantillon de cartes qui est fait à la main et un autre échantillon de cartes qui a été amélioré par l'utilisation des outils des systèmes d'information géographiques. Et ensuite, nous allons vous présenter aussi la démarche que nous avons utilisée dans l'analyse de l'estimation de la population liée au nombre de sites de distribution. Et bien sûr, nous allons aussi parler des leçons apprises et des recommandations. Aussi, là, nous n'allons pas aller de toutes les leçons apprises et recommandations, mais nous avons sélectionné certaines que nous trouvons pertinentes. Et nous allons aussi vous présenter les outils qui ont été utilisés et bien sûr, viendra le temps de questions. Pour l'arrière-plan du projet, il y a un intérêt de plus en plus pour la numérisation de la campagne, pas seulement de la campagne de masse, de façon générale des campagnes de santé. Et la campagne de masse MEDA a aussi bénéficié déjà des expériences qui ont été acquises pour la digitalisation d'autres campagnes. Et donc, nous avons eu le support, par exemple, de l'équipe de l'UNICEF qui a fait une expérience dans ce domaine-là, dans le cas de l'immunisation et de la vaccination. Et nous avons aussi le soutien de l'équipe de l'OMS, de l'équipe NGS, de l'OMS qui nous a soutenus tout le long du processus. Et les deux districts objets de notre projet pilote étaient Mairie Sud et Kabezi. Mairie Sud en zone urbaine, une zone très peuplée, et Kabezi en zone rurale. Et donc, voilà un peu l'arrière-plan de ce projet-là. À gauche, vous pouvez voir, c'est le Burundi. La carte du Burundi et les différentes régions administratives du pays, de province, je pense. Et à droite, nous avons les deux districts sanitaires objets de notre projet pilote, c'est-à-dire Mairie Sud et Kabezi en zone rurale. Les livrables. Les livrables qui nous étaient soumis, en fait, sur lesquels nous devons travailler, consistait à développer des ensembles de données, de collecter des ensembles de données, de développer des cartes, des applications aux besoins, récolter le plus d'informations et développer des produits qui étaient en lien avec la numérisation et en lien avec les objectifs de numérisation de la micro-planification. Ensuite, nous devions planifier et préparer un pilote, un atelier qui devait nous permettre de produire les différentes cartes par différents districts sanitaires, c'est-à-dire le district Kabezi et le district Mairie Sud. Et donc, c'était l'une des parties les plus importantes du projet, c'était l'atelier de mise en place et de confection des différentes cartes par district sanitaire, où nous avons eu la participation de chaque aide de responsabilité, des personnes qui venaient de différentes aides de responsabilité, qui ont participé à cet atelier-là. Et cet atelier a consisté à les aider à leur expliquer le bien fondé d'utiliser les outils GIS, les amener à utiliser les outils GIS et puis les amener à produire eux-mêmes avec notre aide les cartes de leurs différentes aides de responsabilité et les sites de distribution de chaque aide de responsabilité. Et bien sûr, nous devions aussi produire un rapport technique qui faisait le résumé, qui incluait les leçons apprises, les recommandations et évidemment le passage à l'échelle. Vous pouvez voir par exemple à gauche de l'écran une carte qui a été développée à la main, dessinée à la main, comme ça se faisait par le passé. C'est la carte par exemple du centre de santé de Kinendo. Et à droite, vous voyez par exemple le centre de santé de Kinendo qui a été développé avec des outils numériques que nous avons utilisés, qui consistait à améliorer ce qui se faisait à la main. Donc, on voit tout de suite la différence. Tout de suite, vous voyez par exemple que là, ils ont mis par exemple le lac Tanganyika à droite, alors qu'en fait, le lac Tanganyika, il se trouve à gauche. Nous, on avait le privilège d'avoir des outils et une carte à haute résolution qui nous permettait de travailler non pas à l'aveugle, mais avec vraiment des niveaux de détail qu'on pouvait percevoir sur les différentes cartes que nous avions durant l'atelier. Mais évidemment, ceux qui ont fait la carte à la main ont eu du mérite, mais évidemment, il manque de précision. Il s'est aussi posé la question de combien de sites de distribution nous devons établir par district sanitaire et par aire de responsabilité. Et par exemple, l'équipe classique de microplanification utilisait des estimations de population qui sont produites par l'institution de statistique de Burundi. Ils faisaient des projections avec, et donc c'est sur la base de l'estimation de population produite par l'Institut de statistique de Burundi que l'équipe de microplanification établissait le nombre de sites. Mais nous, pendant l'atelier, on a décidé de choisir, par exemple, l'estimation de population venant de World Pop. Et quand nous avons décidé de choisir l'estimation de population venant de World Pop, nous avons fait des analyses de population en utilisant les critères qui nous avaient été partagés avec le Programme national de lutte contre le palud. C'est-à-dire qu'en fait, que chaque site de distribution, il ne devait pas avoir plus de 1584 familles. Et chaque site de distribution devait être dans une zone de pas plus de 3 km. Évidemment, le critère de 3 km s'appliquait très bien en zone rurale, mais le premier critère, il est beaucoup plus, il s'appliquait davantage en zone urbaine, c'est-à-dire en mer du Sud, par exemple. Vous voyez, par exemple, dans le tableau en dessous, nous avons les différents aides de responsabilité que composent Mairie du Sud, c'est-à-dire Lusaga, Kanyosha, le Ziba, Kinindo, Tusoro. Et vous voyez ici, par exemple, le nombre de sites qui avaient été établis durant la campagne 2019 et le nombre de sites qui avaient été décidés par l'équipe de microplanification classique pour cette année, pour la campagne en 2022. Et ici, vous avez les sites de distribution avec lesquels nous sommes venus quand nous avons fait l'estimation de population en utilisant les outils, en utilisant l'estimation de population de World Pop. Et vous verrez ici la différence. Je vous donne un exemple simple. Nous avons prévu 14 sites de distribution après avoir fait l'estimation, l'analyse d'estimation de population liée au nombre de foyers par site. Nous sommes arrivés à 14 sites de distribution et par exemple, l'équipe de microplanification classique avait décidé de 11, alors que nous avons décidé 14. Et si vous voyez, il y a un écart de 10, de différence de 10 sites entre ce que nous avons, sur lequel nous sommes arrivés après l'analyse d'estimation de population par aide de responsabilité, et celui qui avait été choisi, décidé par l'équipe de microplanification classique. Et donc, voilà, par exemple, une différence majeure que nous avons apportée à l'équipe de distribution, à l'équipe du PNLP, qui s'occupe de la microplanification. Et ils ont même accepté et adopté le nombre de sites de distribution que nous leur avons proposé. Et ce qui était réconfortant pour nous, c'est que pendant l'atelier, les participants de l'atelier ont trouvé que les chiffres de World Pop reflétaient beaucoup plus la réalité sur le terrain, pour une raison ou pour une autre. Et donc, c'est notre choix d'utiliser, par exemple, l'estimation de la population selon World Pop. Et nous avons fait face à des défis. Et l'un des défis auxquels nous avons été confrontés, c'est par exemple le conflit en termes d'espace de juridiction. Quand il s'agissait vraiment de délimiter les différents espaces de juridiction, par exemple des aides de responsabilité, on s'est retrouvé dans des situations où les aides de responsabilité ne connaissaient pas forcément très bien leurs limites, surtout entre la zone urbaine, les limites entre la zone urbaine et la zone rurale. Et donc, on était un peu embêté dans le sens où il n'y avait pas quelqu'un qui était capable de faire l'arbitrage. Et donc, ça, c'est une leçon qu'on a tirée, c'est qu'en fait, il faudra avoir quelqu'un pendant les ateliers, quand on fait ce genre d'exercice, quelqu'un qui peut faire un arbitrage, qui peut décider un arbitrage et qui a aussi le profil et l'autorité pour le faire. Et nous, pendant l'atelier, c'était un peu difficile de ce point de vue-là. Et aussi, une chose, c'est qu'en fait, il faudra améliorer les compétences dans l'utilisation des outils, des systèmes d'information géographique dans les différentes équipes qui s'occupent de la distribution de masse, qui font la microplanification de la distribution de masse de moustiquaires. C'est quelque chose qui manque et la plupart de tous ceux qui participaient aux ateliers n'étaient pas des familiers des outils GIS. Et donc, c'est quelque chose à y penser, à développer des modules de formation à leur endroit. Puis ensuite, nous avons essentiellement utilisé l'application ArcGIS Online qui nous a été donnée gracieusement par l'OMS. Nous avons accès avec 3 ou 4 comptes, je pense, mais en fait, la difficulté vient du fait que tous n'ont pas forcément un accès à Internet avec aisance dans les différents aides de responsabilité. Et donc, ça peut être difficile pour eux plus tard s'ils doivent accéder à cette plateforme, d'y accéder parce qu'il peut y avoir des soucis de connectivité. Et donc, on fait le plaidoyer quand même pour que, en fait, dans l'éducation sur les outils numériques qu'on leur donne, ils puissent aussi avoir des logiciels comme le logiciel libres, l'open source de QGIS, qui est simple à installer et qui quand même demande certaines compétences, mais au moins, on n'est pas obligé d'avoir une connexion Internet. Et puis, une chose aussi qu'on a tiré comme leçon en réalité, c'est qu'en fait, les données qui sont disponibles sur plusieurs sites Internet sont des données qui sont assez, sur lesquelles on peut compter. Parce qu'en définitive, quand on a essayé de récupérer et rassembler des données avec des institutions localement, ça n'a pas été aisé et facile, et parce que les gens en manquaient. Et donc, les sources de données sur Internet nous ont beaucoup aidés. Et donc, une chose aussi qu'on a remarqué, c'est qu'en fait, le choix de l'estimation de la population, surtout quand un pays n'a pas les chiffres les plus récents du recensement de la population. Ça, c'est quelque chose qui mérite davantage de discussions, qui mérite davantage de choix sur le dénominateur à choisir concernant l'analyse des estimations de population. Donc, voici un temps soit que les leçons apprises, les recommandations, les défis que nous avons rencontrés. Autre chose peut-être aussi qu'on a rencontré comme difficulté, c'est qu'en fait, la plupart du temps, c'était des gens qui n'étaient pas familiers des outils GIS. Et donc, ce qu'on a compris, c'est qu'en fait, il fallait les aider d'abord à développer les outils, les différents cas sur du papier, délimiter leurs différents sites de juridiction avec cette carte à haute résolution avant de les passer sur l'ordinateur. Pour des raisons logistiques, on n'a pas pu le faire, on les a juste passés sur l'ordinateur et ce fut assez laborieux souvent d'utiliser l'écran de l'ordinateur pour travailler tout de suite. Les outils utilisés. Je le disais tantôt, on a utilisé ArcGIS Online, qui nous a été gracieusement offert, l'accès nous a été gracieusement offert par l'OMS. Nous avons aussi utilisé QGIS, qui est un logiciel open source, qui est téléchargeable, qui est accessible et gratuit sur Internet. Nous avons utilisé l'ensemble de données sur Internet, des données sur le découpage administratif du Burundi, de l'estimation de population de votre des différents centres de santé et des différents settlements, je dirais, abris qui nous étaient fournis sur Internet, par exemple, sur Internet, avec, je pense, c'était quel site déjà, je m'en souviens pas. Donc, bref, pour dire qu'en fait, on peut compter quand même sur les données qui sont sur Internet, qui viennent de sources fiables, comme par exemple le site web de OCHA, le Human Data Exchange, qui est une source fiable qui nous a beaucoup aidé dans le cadre de ce projet. Et donc, on a aussi bénéficié d'imagerie satellite à très haute résolution qui nous a été fournie par les collègues de l'OMS. Et on a utilisé Dropbox pour stocker les données, pour partager les données qu'on a collectées et les documents. C'est toujours accessible. Et puis, évidemment, les postes de travail que nous avons utilisés, c'est essentiellement des laptops, Dell, HP et puis Mac. Et merci pour votre attention et merci infiniment. Nous sommes ouverts pour toutes les questions éventuelles.
Thank you, Fred, for a presentation full of insights and country-specific challenges and practical solutions, which resonates very much with many of the questions that are being asked in the Q&A box. I will ask people to keep questions coming before I hand over the next presenter. I would like also to take this opportunity to welcome those who have just joined us. So for the next presentation, we will go to Russell. Can you project the presentation? We'll go to the Zambia experience, where we'll have our colleagues from the National Malaria Programs in Zambia and their implementing partner. So we have Katie from the National Malaria Program and Derek Pollard from Across, with whom they partner to do a microplanning process using geospatial data. So they're going to take us through the experience of using maps to control malaria in Zambia. So over to you, Katie, then Derek will take over. Thank you.
Thank you very much. Good morning, everyone, and thank you for being part of this call today. My name is Katie Schaloy. I'm the Principal Insecticide Treatedness Officer at the National Malaria Elimination Program, and I will be joined later by Derek Pollard, the Senior Technical Advisor at Across, who have been implementing digital and geospatial solutions to support parts of the malaria program over the last 7 years, and PATH and PMI funding. I will be talking about the use of spatial data that informs Zambia's National Malaria Elimination Program, vector control, planning, and rollout. Next slide. Next slide, please. So the agenda for today's presentation is Zambia's 2020-2021 vector control strategy and use of maps for microplanning. And also we're going to have a brief overview. We're going to also look at data sources to create population and structure distribution maps. And we're going to also look at use of microplan data within review to support our delivery. Next slide. Next slide. Thank you. So firstly, we're going to look back to the 2020 season and discuss what we did to try and achieve effective planning for our malaria vector control programs. So in Zambia, indoor residue spraying and early alliance are the primary vector control interventions, where policy aims to achieve 100% vector control coverage through a mosaic approach. IRS is applied annually and early alliance through mass campaigns every 3 years to safeguard communities which require extensive planning process. However, some of the challenges experienced during the planning stages, where the structure and CSO population data are often inaccurate and do not provide spatial context at the granular level, and the implementing this mosaic approach for 50% IRS and 50% LA line was difficult to operationalize. And so we looked to use geospatial, geo-enabled microplanning approach to help solve these challenges. So if you look at the slide on the screen, go back to the previous slide. The previous slide, please. Okay. Thank you. So if you look at the screen, the grid 3, that's a grid 3 map layout finalized by the National Malaria Elimination Program and partners technical working group. So the objectives that were set out to achieve were to apply the grid 3 products to create planning maps and also to develop and implement a planning template to complement the maps, and also to use the microplanning map data within review in 14 districts to guide RIS delivery. So the maps were produced for all the 116 districts across Zambia to support microplanning activities for RIS and LA Alliance. Next slide. Next slide. Thank you. As we zoom into the map, we see the grid 3 settlements in green and red. So the green represents settlements with 25 structures or more, and the red with 24 structures or less. So the labels on the large settlements show two numbers. So the top number is representing total building count, and the number below is representing the total population count. The small settlement label only shows the total building count. The next slide. The next slide. So during microplanning, district teams physically drew the maps, as you can see on the screen. So these demarcations on the map to show where they plan to implement RIS versus LA, ensuring sufficient resource allocation and ensuring no settlements were missed out. Next slide. So without going into any details here, this Excel sheet just demonstrates the templates used to aggregate the data within demarcations up to district level. Next. So the two main outcomes of the template, as you can see in the red circled areas, were to check if the resource allocation at district level was sufficient to implement RIS and LA line delivery in the targeted areas, and also to ensure that no settlements were unaccounted for in their allocations, even the furthest most remote settlements, thereby planning for 100% vector control coverage. Next slide. So here we see district teams in Western Province microplanning going through the demarcation process on the map and filling out the template. Next slide. So here also is an example of the final district level map demarcations after microplanning. You can see the dark blue areas are targeted for RIS and the green areas are marked for LA Alliance. The next slide. So this map shows the outcome of the map used in microplanning. It highlights districts that may be under or over-resourced in trying to ensure 100% vector control coverage, and if further microplanning discussions needs to be had with particular districts. So as you can see on the map, areas of concern are dark red and dark blue that would have needed additional follow-up. Next. So some of the lessons learned during our grid 3 microplanning was the use of maps much earlier to inform initial allocation during macro planning. Also, health facility boundaries were important to guide accurate health facility level quantification and targeting and integration with DHIS2. The using physical maps presented challenges that could be solved by conducting the whole microplanning process online. And also maps help to understand the accuracy of traditionally used population data, that is headcount and CSO data. Next slide. So before I finish, here is a brief update on improved maps used during the 2021 and 2022 microplanning in some districts with digitized data collection. So the microplanning maps now have accurate health facility catchments mapped by ACROS and show where districts targeted ITNs versus RRS in previous years. And so shows that coverage was previously achieved. So this helped teams make their 2021 and 2022 targeting more realistic. I'm now handing over to Derek to take you through to the end of the presentation. Please feel free to write down any questions in the chat. Thank you.
Thank you very much, Katie. So greetings to everyone on the call. My name is Derek and I'm based in Zambia as a senior technical advisor at ACROS, supporting various health information system projects across the region. As an organization, we provide technical and implementation support to strengthen government health program information systems, as we have done with the NMEP in Zambia for the last 11 years. Access to and the use of spatial data to enhance informed decision-making, largely through various digitized solutions, is a core component of our work and is the topic we will be discussing today. So later on in this presentation, we will be referring to reveal data when discussing first the accuracy of satellite-derived population, and second, using the Reveal mobile app to deliver health services in line with microplans. So I'll start by giving a brief overview of Reveal as a reference for those later discussions. So as you can see in this slide here, Reveal is an open source digital global good tool that is both web and mobile based. Reveal focuses on the use of spatial data to drive effective intervention, microplanning, and delivery decisions, supporting campaigns from start to finish. Next. Reveal enhances spatial data use for critical decisions throughout the typical intervention workflow, solving common challenges along the way. Going through the workflow briefly here, the first step is to build the intervention-specific geospatial data to support microplanning processes on both physical and digital mapping interfaces. Microplanning outputs defined in the online Reveal interface are pushed to the mobile application to support field teams in navigating to intended targets to deliver services. The app provides offline real-time spatial feedback to ensure field teams are effective in carrying out the plan. Lastly, this mobile collected data feeds back into the Reveal web user interface through various predefined visuals to inform critical in-field decisions, post-campaign gap analysis, and future program policy. Next. The goal of Reveal is to use geo-enabled microplanning and field delivery tools to ensure no one is missed, and to provide accurate structure-level data that informs decisions and enhances impact. Next. Reveal is expanded into new countries and numerous use cases that support different programs in malaria, NTD, and vaccination sectors. Throughout the areas we support, two important common themes that are relevant for today come up time and time again. We are often seeing a disconnect between program planning and what actually gets implemented in the field, and therefore this disconnect is reducing impact. And secondly, we are consistently seeing over-reported coverage as well as spatial gaps in campaign delivery. Next. So moving on to the second last section of this presentation, let's look at the data that went into the Zambia microplanning maps that Ketty spoke about that we used control season over the last 2 years. Next. So settlement level population and building footprint counts, including other core geospatial layers, were openly available from the likes of WorldPop, Grid3, and Maxar. This type of population and building footprint data is becoming increasingly available from sources such as RAMP, Facebook, OpenStreetMap, national data hubs, Google, Esri. Some of those have been mentioned on this call already. but certainly we're seeing a big increase in the availability of this data online, which is supporting microplanning processes more and more. It's just a case of figuring out how do we make the most use of that data and make that data useful in decisions. Next. The Grid 3 settlement layer was created from building footprints, as can be seen on the map on the left, showing green building footprints and the resulting white settlement boundary around them. Settlements can also be created from manually digitized building footprints or openly available Google and Esri footprints by defining operational area criteria that meet an intervention's need. We did this for a number of reveal districts across Zambia too, where we defined operational areas as clusters of structures that were within 150 meters from each other and had a minimum number of structures. Next. Population models predicting population counts, as Chris spoke about earlier. We can see here population counts within 100 by 100 meter grids were applied to the settlement boundaries to determine the population in each settlement. Inputs into these models include building footprints, survey data, and others. Population numbers on the maps during the microplanning process. Next. However, one of the main challenges we faced in generating this data for these microplanning maps is that these satellite-derived building footprints include all structures on the ground, but most health interventions are delivered to residential structures only. And so if all structures are used at planning, this results in an overestimation of need. So we needed to adjust all structure counts per settlement to residential structure counts per settlement. So how did we do this? Next. We did this by using field verified structure level geospatial data collected through Reveal during the previous year's IRS campaigns in select districts. And this helped us to model the ratio of satellite derived building footprints to residential structures. And we applied this ratio to all Grid 3 data across the country to get a better estimation of residential structures instead of all structures. Next slide. So in this last section, I want to show how these satellite-derived data were used by digital tools in the field to carry out the microplan and deliver interventions more effectively. Next. So if we look at this 2021 microplanning targeting map, on the outcome here, it clearly defines where IRS is going and where ITMs are going. We digitized the black targeted demarcations that the district teams drew on the maps and loaded them into the Reveal mobile app to guide delivery to the correct areas. Next. This process can now also be done online through the Reveal web-based microplanning tool. We're in the process of making numerous improvements to it, but it's exciting to be implementing this map-based process online as well. Next. Those microplanning outputs in terms of which settlements are targeted and which ones are not targeted are visualized on the field team's Reveal application to guide them to the targeted settlements defined during microplanning, and therefore giving the program the highest chance of achieving impact, given that during microplanning, they're ensuring decisions are made based off of the data that they deem important to achieve impact. Next slide. This dashboard monitors the team's progress in delivering to all the targeted settlements. And you can see settlements in green were reached, settlements in yellow have not been visited yet, and settlements in red were visited but refused. And so this gives you a settlement level view of where teams are going in the field and if they're going to targeted areas. Next slide. This next dashboard is at settlement level, and the Reveal dashboard highlights structure level coverage and gaps where return visits may need to occur. And on this map specifically, you can see all of the yellow structures that have not been visited yet that are very important to visualize for the field teams as they return to mop up and achieve high coverage. Next slide. From this data, post-spray maps can show coverage at district, health facility catchment, and settlement level. As you can see on this map here. And on this map here, you can see all of the health facility boundaries that were mapped by visiting all the health facility teams and ensuring that the right settlements fell into the right health facility catchments, which was extremely important in quantifying the correct population and structure data to each settlement.
Derek, 1 minute left.
Yep, 2 more slides.
Yep. Okay.
A general trend we saw from the data seems to be quite a gap. Sorry, I'm just having challenges navigating the slides forward and back. There seems to be quite a gap between what is targeted and what is actually visited in the field. This highlights the need for more accurate and realistic microplanning. And here you can see there is a 41% gap between what teams targeted and what they actually visited in the field. So to end off with some high-level takeaways, using a combination of satellite-derived population data sets and digitized field-verified data can guide net quantification without registration as a potential option during a single-phased approach. Secondly, taking the microplan process online through Reveal, replacing paper-based and Excel planning tools will help solve logistical and data integration challenges. In addition, door-to-door net delivery recorded through a digital platform can really enhance outputs. Another takeaway is combinations of different mapping and mobile tools can be used across a country to match available resources. There's no one formula that fits all. You can look at different options for different areas based on priority. And lastly, the use of spatial data helps inform decisions throughout end-to-end campaigns and should be used where possible. So thank you. Please see the organizational links and contact details here. Thank you.
Many thanks, Derek. As you can see, some similarities, some commonalities, but also some differences with the Burundi experience. So let's now go to the Nigerian team. Fatima from the National Malaria Program, and Philip also, Okoko from the National Malaria Program, with Farouk Omar from Grid 3, who will be presenting their initiative and experience in using maps for attending microplanning campaign in the Kano State. Over to you, Nigeria team.
Hello, good afternoon, everyone. My name is Fatima Bukar Ali. I work with the National Malaria Elimination Program as part of the IVM team. I'm the IT and focal person for the country. I'm together here with Farouk and Mr. Okoko, who is the head of IVM. All right. Okay, so just to give a bit of a background, here a picture of some of the maps that were previously used. They are hand-drawn. As beautiful as they are, They have some limitations, as mentioned earlier. They can't be replicated, they're difficult to share, and these maps are drawn by hand, and at every campaign, every 3 years, when you go back to state, they have to be drawn up again. And also they are drawn by the ward focal person, so it's from their own perspective, so it's difficult to replicate and share. So in Nigeria, for the digital microplanning, Kano State was chosen as the pilot state, and we got data from the last campaign, which was 2019, and this was shared with Grid 3 with settlement details such as the list of settlements, their population, distance from the LGA store, number of distribution points. That was in 2019. Now we call them hubs because our strategy has changed. We're now doing door-to-door campaigns in Nigeria. So this data from the previous campaign was used to compare our settlement extent layer with the presence of household points, run a spatial average household points to represent village locations as centroids. So Farouk will explain more on these technical terms. Also, it was used to compare the total number of bed nets distributed per village, as settlement or community, against the total estimated population using Grid 3's population estimate. So with that, Grid 3 was able to produce 3 versions of maps for us, one based on population raster, and another settlement travel, and then service area, that's the health facility. So we went with a map that is a combination of all 3 to serve as a base map in the context of our microplanning in Nigeria. Okay, so the base maps were drawn up and they were given unique code to each settlement extent. So the formula was to use the first 2 letters of the name of the local government and the first 2 letters of the name of the ward, followed by the extent number. So the distribution hubs, catchment forms. So these are forms that we normally populate the list of settlements within the catchment area that distribution hub is serving. So this was also updated to accommodate the population extent of each settlement. And then we also developed a Kobo collect form to capture the geo coordinates of new or missed settlements, and also for private DH that is not a health facility. So for a catchment area, you might have 1 health facility, but because of the high population, you might need to split it into 3 other distribution hubs. If there are no health facilities, then we use like the house of the village head or any other secure location that can be used to store the nets and to serve as a hub. So also the maps came along with tables consisting of the settlement list, which were printed out and reviewed. And the maps and the settlement table list was generated for each ward in the state. So in Kano State, we have 44 local government areas, and altogether we have 484 wards. So that means 484 maps were developed. So that's a bit of the background, and I'll hand it over to Farouk to talk about TREAT's involvement in all this. Thank you.
All right, thank you. Thank you, Fatima. Yes, as Fatima mentioned, mentioned earlier, there were a lot of things involved in the production of the maps because it was a huge transition from the paper drawn maps to new GNable maps, which I think there were a series of meetings with AMP, NMEP, and other partners just to come to make sure that we come up with a map that would be useful during the microplanning in May. So a lot of questions were asked in terms of what data they use for the microplanning, what is the standard operating procedure, and then also what is the target for the map. So in the end, 484 maps were produced. That means that because Kano State has about 484 maps, so we have 1 map per word, An example of the map is here. This is just an example of the map. Each map contains the name of the word, and also it's a paper map, but it serves in place as a dashboard also, because it contains not only the points of interest, but it also contains tables, and these tables show the statistics of based on health facility catchment area, because as we discussed with MMP, they consider sometimes health facility catchments as areas that they use. And we also created the statistics at what level, which is the table at the bottom. And these tables contain the estimated population of that particular catchment or ward. They also contain the estimated number of households, and they also contain the estimated number of ITNs, and also the distribution hubs required in each health facility catchment or ward. So they were very helpful, because with looking at the paper maps without referring back to tables, you can easily see the number of distribution hubs that are required per ward. And you can also see that at the LGA level. So the next is, but how can we use the maps? Because we had to conduct trainings, because this is something new, particularly in Nigeria, moving away from the paper maps. So as you can see here, we have different polygons, which are termed settlement extent, which are polygons representing areas where there's likely human settlement on the presence of buildings detected by satellite imageries. And these different polygons are being characterized into built-up areas, small settlement areas, and hamlet areas based on their size and the population they contain. But the advantage of this is because we cannot put the entire localities or settlements on a single map, because that would be congested. So we gave the settlement extent ID, and in each ID, for example, in an urban area, you can have a settlement extent with multiple localities. That maybe a settlement, a built-up area might have like 100 or even or less localities, which we created a separate table containing the settlement extent ID with the different settlements or localities contained within that settlement extent. And not only that, if you look deeply into this map, you can see the figures on the map which show the population estimates of each settlement area. So without referring back to the table, you can easily see what population is contained within each settlement, more of an aggregation of the entire settlements in that particular settlement extent. So you can also see the travel time based, the accessibility between that. And also identification of health facilities on the health facility catchment areas on maps. You can see we have the health facility in the catchment. And then we can see the health facility catchment area boundary. So what we did is, because the maps were made for each word, that's 484 words. And within each word, you could have, let's say, 3 to 4 health facility catchment, because the minimum standard in Nigeria is that you're expected to have at least 1 primary health care within each word. So some have 1, 2, or 3. So that means some could have like 3 catchments. And these catchment areas were generated using friction layer, using distance from the health facility to the settlement areas. So we use 4 kilometers to make sure that the catchment captures or settlement are allocated to the facility that are within 4 kilometers. So from here, you can see the boundaries, which could easily be used by the word focal person to say, okay, this is my catchment. And then you can have multiple catchments within a word. Yes. So the next thing is, after doing these maps, we had to make sure that we understand how to use the maps. And the main thing we focused on was to look at how do we identify problems on the maps. For example, looking at the legend on the map and check how the settlements inside the catchments are distributed. Are they compactly distributed or sparsely distributed? Sparsely distributed settlements are more in rural areas, because for all of us familiar with, for example, Southern Africa or Africa, we know how dispersed settlements are in the rural areas, and that is difficult. That amounts to issues of accessibility. And another thing is to count the number of color red, because we color the red colored show like hard to reach areas in terms of distance. That means you have to travel far from the health facility to reach them, and that shows the need for more distribution hubs in those areas because of the distance from the health facilities to the these settlement areas. And then to note if the catchment has any sort of like physical barrier. And these physical barriers could be water bodies, which are very visible on the maps, could be in terms of topography, which is not as important in Kano, but which could come up in subsequent maybe campaigns in other states like Adamawa with rugged topographies, or Plateau with that which we focus on.
Farouk, you can go faster and
yeah. So I'll just skip this. Yeah. So and then yeah. So this is what I mean by that, because from here you can see the different accessibility index. For example, this is Abuak Aura. It's a catchment area. You can see the facility, and you can see there are a lot of settlements which are even more than 60 minutes walk from that facility. So these are the things that mean that by looking at that, we can easily say, okay, we can create a new distribution hub in those areas. So and then I think we can just skip this, and
yeah, let's go this.
Maybe Fatima will talk about the success and
lessons learned maybe, and then we wrap up.
Okay, all right, I'll try to. All right, so after the maps were produced, we had different levels of training at the state level on the maps and how to use the Kobo Collect. And then this was cascaded down to the LGA level, where the LGA team, the ward focal person, and a ward community development representative was part of it. So the team were expected to review the maps, update it with information such as confirming the name, the location, the population of the settlement, each extent, is it labeled correctly of that settlement, if an extent is a settlement or just an abandoned, farmhouse that nobody lives in. So, all that kind of information to update and give us a truer picture of what that's like. So at the end of all that, they submitted their updated maps with the settlement list and of course the Kobo Collect updates at the state level for collation and validation. So for the last key achievements, the most important thing was the end users found it easy to understand and use, and there was no need for the hand-drawn maps at every microplanning in the state. The end users, that the ward focal persons and the officers in charge, were able to easily identify with the maps and easily make modifications or corrections, especially in terms of ward boundaries and in the context of IT and campaign. The new DH and the missed settlements were successfully recorded, and using the Kobo Collect was not a problem. I'll quickly move on to the lessons learned. The digital maps were updated with all the correction made, and this will be a good foundation for subsequent micro-planning activities in the state. Issues of missed settlements was greatly minimized, which was very good news for us. So this will help ensure proper coverage during implementation. The final updated maps will make it easier to identify and monitor distribution hubs during implementation. We're able to work closely with the focal person to resolve the issue of definition of a settlement, especially in the metropolitan, where it's highly populated, and sometimes they use line listing instead of like a proper settlement in the rural area. So it allowed also opportunity to have another source of data for population of different settlements. That's the population provided by Grid 3 compared with ours from previous campaigns and other health interventions. So for the challenges, we had some issues of mix-up of the settlement names and health facilities in between the wards or the local government. So you might have a health facility that is supposed to be in Ward A, but it was captured in Ward B. So these were some of the corrections that the end users were able to do. Another challenge was because they have to go out to get the geo coordinates for a new settlement or a new distribution hub. This was not captured in the logistics. But however, the LGA team was able to give support, which was quite fantastic, and improved community ownership. We didn't get to utilize the distance feature of the digital map, but however, we plan to use that hopefully during implementation. So among the next steps, the experience and lessons learned will be used to develop a precise work process and a detailed SOP for the national team, the ward, and the LGA team. The updated base maps with the following information. I've said that. Okay, so the updated maps will have now been designed to have catchment area based on the distribution hub, and it's also linked to the P3B template. That's a template we use for micro planning, as well as taking into consideration all the resolved boundary issues. There's plans for transfer of knowledge and explore the possibility of integration of this digital map into the ICT4D system. As you all know, in Nigeria, we use technology ICT4D for our campaigns.
Thank you, Nigeria team. So we're running a bit behind schedule. I will ask now the last presenter, Nick. We're going to hear the experience in South Sudan with Nick. It's not related to ITN specifically, but something that can be applied to micro planning for ITN campaigns. Over to you, Nick.
Thank you very much, Giovanni. And I'd like to say a big thanks to all of the organizers and of course the participants for inviting me to present to this session. I'm going to start very quickly by explaining what Map Action is, because I imagine it's not a familiar NGO to most of you. I'm going to explain the problem that we aim to address in the digital micro-planning process. And I'm going to try and explain the solution that I'm going to talk about today, this data package. And finally, the main part of the talk is to share the experience of applying this data package in a pilot project in South Sudan last year. So I'm just waiting for this slide to advance. Yes, Map Action was established about 20 years ago. It's a non-profit organization. It's based in the UK, and its broad aim is to use geographic information and data and analysis, especially in the form of maps, to support all humanitarian activities. We've activated well over 100 times now to different emergencies around the world. And most of our specialist work comes from volunteers. They're professional GIS and other IT experts, but they also act as volunteers. So we actually have a very good model for responding quickly to emergencies. In the past 10 years, we've become much more focused on training, capacity building, and preparedness activities. This is our broad mission, as you can see on the statement here. And the way our project started in relation to microplanning was broadly with a concern for equitable and inclusive immunization against COVID-19, just to echo the principles that Chris set out at the beginning. This map shows you the picture at the end of 2021, and it's very clear that this does not show an equitable picture of distribution. So during last year, as the supply of vaccines became less of a challenge, we looked at how we could use geospatial benefits to support in-country distribution in a way that wouldn't duplicate other initiatives. So we joined the GIS technical working group that Chris mentioned, now the community of practice. This has been extremely helpful. And just to explain the relevance of this work to the webinar now, we see that this solution that we've got as relevant to any public health campaigns, such as ITN. The requirements for data are very similar between immunization and ITN planning. And as we're seeing more and more, they can be integrated. In a way, we don't need this slide because all the previous talks have shown the underlying data themes that are needed for digital microplanning. And the pictures on the right are really emphasizing this concept of airport to arm, as it were, for vaccine delivery to get into people's arms using microplanning tools. So this is the area in which we've tried to identify where map action can support. This diagram shows in a very general way how geospatial data and techniques can be used to support health campaigns. Starting at the bottom, we've seen that data is used to support tools. Those tools support microplanning, and the microplanning supports the outcome, the equitable immunization program, or it could be an ITN distribution. This is very general. And we've seen examples of the types of tools that I'm talking about: accessibility modeling, population per distribution site, catchment areas, and so on. So where is the problem that we've seen on this in this chain of data? And I actually need you to imagine a red circle in between the data and tools. I did have this on the slide, but I've left it off for some reason, sorry. So just imagine like a red circle between the data and tools where the arrow joins them together. And this is what I call the data bottleneck. More specifically, we're looking at the amount of time, cost, and expertise needed in data preparation. And I'll explain this more in the next slide. And just to be clear before I move on, we aren't aiming to be a data producer. This is being done brilliantly by Grid3, for example, by national mapping agencies, by UN, OCHA, and of course the big tech giants increasingly like Google and Facebook. And you've seen examples of that. So just to explain what I mean by this data preparation bottleneck, oh yeah, sorry, just a little quote: the tool is only as good as the underlying data. Here's the sort of bottleneck I'm talking about. A typical data preparation workflow is something like this. And I imagine lots of the other speakers are familiar with this. If I think of an example for South Sudan, when we started looking for population data, we found 5 or 6 different sources. That's step one. We had to evaluate each possible data source. Now, these are from different years, and they're using different methods, and there's different levels of accuracy. There's all sorts of issues associated with different data sources. Or it might be there's not enough data to choose from, in which case you need to look for new sources. Evaluate data sources, select the most fit for purpose, which one is going to suit you best. The data cleaning process, and those of you who are involved at the technical level will be very familiar with the data cleaning process: finding gaps, finding duplicates. Is it consistent? Does everything have a coordinate system? In order to feed into most analytical tools, you need a consistent data model. The file names need to be consistent. The field or the column names need to be consistent. We need to make metadata. In order to cross-reference layers, we need place name codes, and they've been mentioned as well in the talks. Now, on my screen, some rows have been left off. I don't know if that's the same for everybody, but after place name codes, I've got documentation. This data is only really useful if it's documented so the end user can understand it. And finally, the process of a sensible file format, which is ready for whatever analytical system you're going to use, such as QGIS, or it might be DHIS2. And DHIS2 presents a lot of challenges in terms of spatial data import. So why is this a problem? Well, here's a list of the typical sorts of problems that we see over and over again in all work that Map Action does. It's all these preparation steps are effectively barriers to adopting geospatial tools. They're difficult to automate. And they take a lot of time. for skilled staff. That in turn costs a lot of money. It creates an opportunity cost. Skilled health workers spend their time preparing data, and it can result in duplication of effort between agencies. If 5 agencies are involved in a campaign, you don't want to have 5 agencies each repeating the steps. So just as an example, this was a presentation to the GIS COVAX working group last year. It was a really excellent piece of spatial analysis looking at geographic accessibility to COVID-19 services in 4 Southeast Asian countries. Now their timeline, they shared this as a lesson learned very kindly. Their timeline in red is the time they spent on data preparation, and in blue is the time they spent on data analysis. And they concluded that it still takes 70 to 80% of a project's lifetime to address data-related issues to conduct this type of analysis. So this is the sort of problem that we see time and time again. So the solution that we came up with, and it's actually a very simple concept, is to create a ready-to-go, ready-to-use package of geographic data, which has been selected, it's consistent, and it's been checked, along with supporting documentation and any useful tools. And crucially, it's designed to meet the needs of a specific use case, humanitarian, or in this case, a public health use case. Now, I was quite surprised that we didn't see a similar concept has been used before. But the idea is that a specialist agency or a group of agencies can work on the data, and then it can be used by the Ministry of Health, WHO, whoever is involved in implementing an immunization or ITN program. This is a little summary of the benefits. I've touched on most of these already. Maybe I can just focus on, at the end, adaptability and scalability. This approach of a data package can be adapted to any public health or humanitarian application, and it's scalable to any geographic area. It could be a city, if that's the focus of a campaign, or it could be a country, or it could be a whole region. So we got funding early last year to run a pilot project, in effect, as a proof of concept.
Nick, so can you go maybe to the what we did and the findings, maybe?
Yes, certainly, yeah.
Yeah, let's move faster.
Yeah, okay, no problem. Thanks, Giovanni.
Yeah.
I'll just move on. We chose South Sudan because at the time it was about to start its COVAX rollout. This was our broad implementation process. I'm not going to go through it all, but it's really just showing how the requirements for vaccination delivery determines the contents of the data package. Now, we got a good idea. We based the contents of the data package on published UNICEF and WHO literature. This was already well known. And of course, we use these publications here, but of course, there's now the handbook that Chris talked about. We worked with 5 partners. Our donor enabled us to bring in expertise. Again, this has got cut off on my screen. But this includes Liverpool School for Tropical Medicine as well, and also Esri. In terms of the actual, what does it look like if you open a data package? This is the typical structure of it, and this is the one we used for South Sudan. It's got the basic data, it's got metadata, it's also got ArcGIS and QGIS projects, so you can open it straight away. You don't need to make your own project with symbols and so on. We also included various little bits of code and utilities, like for supporting data collection in Excel or Kobo. And the narrative, in effect, is a very detailed documentation. We published it last year, so anyone can download it. And in terms of actually implementing this to see if this concept was useful, we worked in Juba with Ministry of Health and other organizations, WHO Country Office and an NGO, South Sudan Healthcare Organization. We got an incredibly good reception. I was actually quite surprised. Everybody we talked to liked it. We talked with the health cluster, we talked with the Emergency Planning Committee and others. Some people were interested in using it as a package, others were interested in just individual data layers. One big message that came out was that DHIS2 integration was important. In terms of next steps going forward, well, actually this year we worked with the National Anti-Malaria Campaign, PNILP, in Burundi, and hello to colleagues there. They were wonderful hosts when we visited Burundi, and we did a very useful training program in Kobo as part of their digital microplanning process, and that's a relationship that we have funding to develop. We are planning to increase or develop the potential for DHIS2 to use this data in microplanning support. And we also just recently have got funding for 2 to 3 years of work to develop the data package concept in microplanning in 3 or 4, maybe 5 countries. So that plan is underway at the moment. I know we're short of time, so I will stop there and hand back to Giovanni. Thank you very much.
Thank you so much, Nikki, and all the presenters. So we're going now to move into the question and answer session. I can tell from the chat line that we have over 21 questions. The first question is, what are the implications in terms of resources, be it human, finance, material, technical, time-wise? So what are the implications in terms of resources of this approach compared to the approach that we are currently using for microplanning for ITN campaigns? So I will put this question to all the presenters, starting with Chris, and then to the other presenters following the order in which they presented. Chris? Did you get the question? You are on mute, Chris.
Thank you. Sorry, I caught part of the question, but is it in the chat? Which one are we doing again?
So it's a combination of different questions which are related. So the question is, what are the implications in terms of resources, human resources, finance, material, technical, time of this approach, skill-enabled approach, compared to the current approach they are using for microplanning for ITN campaigns?
It's a very good question. I think we should step back and look at it kind of from a holistic sense, because there is some work that's required to go into setting these programs up, setting the capacity, developing the data sets, doing the upfront analysis. But it also can give us efficiency gains in terms of making sure we better use our resources in the actual ITN distribution process, that we have the fewest number of people to effectively reach the greatest number of population. So the overall cost of these programs can be minimal impact, because we require less extra staff, there's less waste, there's more optimization in terms of how quickly we can do the programs when it rolls out. But yes, we do need some upfront work. There is some time to develop the underlying data sets, which is the efforts that MapAction is working on and similar. There's work as far as capacity development within our ministries and within the districts to learn these skills. Much of the software is either open source or can be granted in licenses by WHO. For instance, ArcGIS Online, we do have licenses available to our partners and ministries of health. That shouldn't be a problem. So the costs can be pretty minimal in terms of dollars. It does take some time up front, and I think the more time you have, the more you can limit the financial cost.
Thank you for this. So maybe I will turn to the people who are implementing these in the fields to give their feedback. So what are your thoughts, Zambia, Nigeria team? First, Zambia.
Thank you very much. So for Zambia, with regards to human resource, I think we do have sufficient human resource at district level who are able to do the demarcations and the planning during our micro planning. So these are work with the malaria elimination officers. So the only part that was costly was where you do draw the maps, but then those maps have to be developed and printed for all the 116 districts. So there's quite a cost implication on that. But then the other parts, we had the resources to conduct, especially that we had support from our partners. I'll hand over to Derek if there are any additions. Thank you.
Thanks, Katie, and thanks for the question. I think that there's an increasing amount of openly available data and ways to generate that data, and so it's fantastic to see this data being brought into different countries' approaches to support microplanning. But that data is, there is some level of data that needs to be generated by the country themselves. They need to recognize the importance of using, including spatial approaches within their programs and investing in certain amount of data that is important for the decisions being made. And I think one of those is health facility boundaries. It's the common, often the smallest unit of at which microplanning quantification is done. And so having accurate boundaries really helps to not only understand, use and understand the spatial data sets within them to understand population and structure counts, but also to then measure your interventions, your intervention coverage against. So I think it's important for programs to understand that there is a certain amount of investment in generating their own spatial data that suits their microplanning needs alongside all of the openly available data.
Any thoughts, Fatima and Philippe, before moving to the second question?
Yeah, so in terms of costs that are associated with carrying this activity out, first of all, the printing of the maps required quite a number of costs. Like for instance, what Fatima said earlier on, this activity was done in Kano State, and it had 44 LGAs, over 400 wards in these 44 LGAs. And we needed to make maps for each of those wards. And of course, these maps, the base maps, had to be reviewed and eventually taken back for updating of the maps, and then eventually reprinted again. So these are all associated costs. to carrying out this particular activity. And I think that's the heaviest portion of it, apart from probably the engagement of consultants that supported the process. Thank you.
Thank you. A related question is, countries are engaged, currently many countries are engaged in digitalization of ITN campaigns. How can this approach be integrated within the overall digitalization process? What are the main challenges and what are the recommendations for programs? This question for all. Again, maybe we can start with Nick, who wasn't involved in the first question. Did you get the question, Nick?
Sorry, I was just looking for it in the question list, but I didn't see it.
No, we've been combining questions which are related to make it easier. So the question is, countries are engaged in digitalization of ITN campaigns. How can this approach be integrated within the overall digitalization process? What are the main challenges and what are the recommendations for programs, national malaria programs?
Yeah, and I guess you can see this very broadly in terms of a national spatial data infrastructure, as it's called, which supports, it's the mapping, the geographic information that supports not just health programs, but all areas of national development and administration. So ultimately, that's the best way for digital data to be created. But I think we've seen time and time again that investment in a digital approach can be reproduced very efficiently in other health campaigns. So yeah, a lot of efficiencies to be gained there from the investment in a digital approach.
The question that's addressed to Zambia team. In my understanding, planning is done based on the population of the targeted area. So how do you determine the population based on geolocalized data? Derek and Katie, over to you.
Yeah, thank you very much. So during planning, we do have quite a set of population data sets that we use. So we do have the CSO, that's census population, and this is done every 10 years. And the last one we had was in 2010. So, and this is when we are having, this year, this is when it just ended. So we've been heavily, for program implementation, we've been heavily relying on headcount. So we do have projections, CSO projections, and then we do have the actual headcounts. And then we also have the geospatial populations. So this is why you now try and cross-check which populations estimates we are going to use. So we have all these sets of population estimates, and these help us to validate what type of population we're going to use. And it has really helped the country in as we are doing our planning. So even as we enter the data in our DHIS2, you do, in the malaria instance, you're going to have at least headcount population, CSO, micro-planning data population, and also the grid 3 population. So we do look at all these sets of population and pick which one represents the target areas or the target provinces well. And of course, we do have, during our validation, we put at least a 10% variance, that if it's above that, then you have to really go and cross-check and see how that data was arrived at and if at all there are any anomalies. So during our planning, that's how we do the cross-checking, and those are some sets of population that we work with. Thank you. Derek?
Just to emphasize what you've said, Katie, yes, it's really important within the decision-making process around quantification to have that validation process, where some districts might have really accurate headcount and CSO data, or especially headcount data, but we often see that the headcount data is not always accurate and reliable. So to be able to have a data set that has been generated in a very generic way as an alternative data set to validate against has been really useful in that validation process, and also to then direct supervision to those districts where it does seem to have quite a big difference between their own populations and openly available populations.
Thank you. Question for Nigeria, Farouk, what tools were used to model accessibility in terms of travel time?
Yes, thank you very much. I think what we did is we tried to use different accessibility measures. At the beginning, we proposed a service area, which we wanted to make sure that each settlement extent was given a right distance. But in the end, we realized that we needed to bring friction surface analysis to actually make sure that every impedance is taken into account in terms of the topography, in terms of the type of road, and all that is taken into consideration because of to get the exact, not like a more precise distance from the facilities. So, and we also used that for the catchment as shown to make sure that we get the nearest settlements allocated to the health facility catchment. Thank you.
Thank you, Farouk. Another question for map action. In case of population displacement after the microplanning, how is this shown on the map and updated and aligned for the monitoring of the progression of teams?
Giovanni, I missed the first few words of the question, sorry.
In case of population displacement or movement after the microplanning, how is this shown on the map and updated and is aligned for the monitoring of the progression of teams?
Yeah, I suspect this is a question others can answer better than I can with experience of situations like that. We didn't have to face this in our work directly, but we have marked this, flagged this as something to work with other data sources, other data providers, such as Institute of Migration and UNHCR on, in order to how to dynamically incorporate changes due to population displacement. But yeah, it's a very challenging question. And I'd be interested to know if others have answers about that.
Any thoughts, Katie, Derek?
Just a brief thought from our work in Senegal, where we're supporting digital data collection for onchocerciasis, which is a neglected tropical disease. On the borders of Senegal, they have a lot of cross-border movement between Senegal and Mali, and so while I think one approach is to look at the models that help support, help understand population movement and adjust accordingly, I think collecting more granular spatial data can help inform a program's understanding of what level of population movement there is. As a brief example, for mass drug administration across many programs, including NTD, you do multiple rounds of mass drug administration. And so by collecting individual person level data between rounds, you can get an understanding of what percentage of people are still at their places of residence between rounds, and therefore start to understand what level of population movement you're dealing with that might be able to help your program policy in the future. So I think both addressing this from an improved data collection standpoint, an improved modeling component that I know a number of groups are working on, but then of course, in the field, making sure that teams on the field who are actually working in those areas are contributing to the data and the understanding of what actual movement is happening is also equally as important.
Thank you, Derek. So one last question. We have a lot of questions, but we're running out of time. One last question will be for Chris, I guess. Is there a place where geodata could be shared so that it is accessible to more organizations? In our work, we would often benefit from good quality maps, village lists, and we would also be happy to share this type of data.
Well, yes, there are quite a few of these out there, and I think maybe that might be part of the problem is that there isn't one place to look. There's, there's HDX, which has a lot of the humanitarian data that we might need. There's other layers. WHO has quite a bit of internal information that we can make available to partners, but sometimes it's not generally publicly available. Data sharing and this availability of data within countries and between countries is something that we do need to put more emphasis on, especially looking at this cross-border issue that was just brought up. It's quite useful for Burundi and DRC, for example, to share that data on boundaries, on populations near the borders. Yeah, so I think there are a few forums that are set up for that right now, but better visibility into exactly where people can go and look is something that we are working on too.
Yeah, maybe one last question really. Under what conditions like example, census quality of civil registration data, are the inputted official population statistics considered reliable? Chris,
if I can say just something on that, and then I'll pass it off to the others. It's quite easy to poke holes in satellite data. Even if your imagery is a month old, you can always point to that house that was built last week and say, look, it's not accurate. But accurate isn't yes or no. We have to compare it to a baseline. Is it more reliable than what we would be using if we were not using this data? And in that context, I think it's quite easy to say that it's reliable enough to say that it's better than the hand-drawn maps that are done by memory from our communities in most cases already. And once we start using these systems, if we build them in the ways we want to build them, they are going to be self-improving. So as we find mistakes in them, those mistakes will be caught and captured and reinforced, and the product will, between this campaign and the next campaign, it will greatly improve. Between the routine work that's done this month and the routine work that's done next month, it will improve. So all we need to do is get it to the point where it's better than the alternative right now, and it's time to switch.
Good. Thank you, everyone. In the next 60 seconds, we'll be wrapping up. So on behalf of everyone who has attended today, and we did speak at some time at 205 person online, I would like to thank our guest speakers for sharing their experience and insights as well as their time. There's a questionnaire. If Russell, if you could put the questionnaire in the chat box. So we'd like to complete that questionnaire in order for us to have feedback about the webinar. I think we got a lot out of today. Thank you very much for participating. A recorded version of this webinar will be available, and we'll be sharing with you all the presentations and contact details of the speakers. Should you have any further or follow-up questions, or just want to keep the conversation going. On the notes, I would like to wish you, did you put the Russell? Okay, the questionnaire is there. If you can just complete it. On that note, I would like to wish you a nice day, nice afternoon, good night, depending again on where you are. And thank you again for attending this webinar.
Thank you very much, Giovanni and team.
Thank you, Giovanni.
Thank you, everyone. You did well.
Thank you much, everyone. We will now end this meeting. Thank you.
Thank you, everybody.
Thanks to the participants.